I'll be talking to you today about quantitative assessment of liver tests with the focus on breath tests. Over the next 15 minutes, I'll talk to you about the principles of breath tests just so that we understand what this is. Unlike the other tests that we have heard about yesterday, this is not something that's common. So we'll review the principles of this breath test. We'll talk about what the state of this breath test are in fatty liver disease currently in 2017, and then we'll focus on potential applications, both research as well as clinical applications of breath test. Now, why do we need quantitative liver tests? Well, from a liver perspective, from an organ perspective, we're far behind other organ systems. So unlike the heart, the lung, we don't have a functional test. For heart, you have a cardiopulmonary stress test, which can assess both heart tests as well as pulmonary capacity. You can measure creatinine clearance and renal function. We have no such test for liver disease. The imaging and serum biomarkers that we do have are able to distinguish between disease, no disease. They can distinguish inflammation, fibrosis. However, they're not able to provide a hepatic metabolic function. And this is important because as patients progress along the disease spectrum and develop fibrosis, and as eventually develop cirrhosis, they have a reduction in hepatocyte mass and increased portosystemic shunting. And as those two parameters worsen, they develop clinically significant morbidity in the form of complications of portal hypertension and mortality. And although liver biopsy can quantify hepatic fibrosis, it does not measure liver function or hepatic reserve. So it should come as no surprise that quantitative liver tests are better predictors of outcomes than liver biopsy. For instance, MEG-X was more reliable and sensitive indicator of outcomes in patients with cirrhosis. Now, breath tests are not new in the field of hepatology. They have been around for decades since the advent of stable radioisotopes. And these are some examples of how they have been used in chronic liver disease over time. Galactose breath test has shown to predict severity and complications in patients with cirrhosis. Phenylalanine breath test has been used to monitor liver regeneration following partial hepatectomy. And then caffeine breath test has been shown to predict improvement in hepatic function in patients with chronic hepatitis B after lamivudine therapy. Now, this slide highlights 2 points that I'd like to make. First is that there are a number of potential probe drugs that have been used in chronic liver disease to assess quantitative liver function. But also, there's a variety of applications that have been used from predicting clinically relevant complications and then response to therapy. Now, before I get deeper into this talk, let's review how a breath test is done. So what happens is a patient ingests a radio-labeled probe drug. The drug is absorbed and then eventually metabolized by the liver into a chemically inert or biologically safe compound, NCO2, which is subsequently expired and can be measured. And the ratio of radio-labeled carbon versus C12 can then give us information about liver function. Now, a major principle of breath test is hepatic clearance, and that's related to hepatic perfusion and extraction rate or extraction ratio. So drugs that have a high extraction ratio provide information of liver flow and thus are limited by blood flow, or blood flow limited. In contrast, prodrugs that have low extraction ratio are limited by hepatic metabolic capacity and thus are enzyme limited. Now, the location of the rate-limiting enzyme tends to provide useful information in regards to microsomal activity, systolic activity, or mitochondrial activity. So this shows what an output of a breath test looks like, and it measures delta over baseline and plotted against time. And as you can see, there's this peak. And so one potential outcome that can be measured in these patients is time to peak. How long does it take for patients to get to that peak? Another potential endpoint is the height of the peak. And then finally, another thing that can be looked at is how much of the drug is recovered after that's given to the patient. So all these represents potential outcomes in patients undergoing breath test. Now, this slide shows the breath tests that have been evaluated in fatty liver disease, and they're broken down based on hepatic function. And as you can see, there are a number of candidate prodrugs that have been evaluated. Some of these are limited by high extraction ratio, some have low extraction ratio, thus they measure portosystemic shunting. Now, instead of going over all the trials that have been done, I'm going to focus on metastatin because there is some very promising data with metastatin breast tests, or MBT. So when patients ingest MBT, it gets metabolized by hepatic cytochrome P450 into low doses of Tylenol and formaldehyde, which is subsequently rapidly biotransformed into CO2, which can then be measured. This is a proof of concept study in patients undergoing liver transplantation in whom metastatin was injected via IV, and then it was measured over time. And as you can see, when during the anhepatic phase, when there's no perfusion to the liver, MBT is not metabolized and the line is flat. However, with reperfusion, there's an increase in the signal out, suggesting and underscoring the importance of liver in metabolism of MBT, or metastatin. This is another way of looking at the same data, and it shows MBT in liver regeneration after partial hepatectomy. The dark blue, I don't know if this, so you can see here, prior to surgery, patients have a nice early peak. However, after hepatectomy, the peak is blunted and the time to peak is delayed. And as the liver regenerates and liver mass increases, the peaks gets higher and it starts to get the time to peak starts to shorten, suggests recovery of liver. And as the liver has fully regenerated, the peak resembles the peak prior to surgery, once again underscoring the importance of liver in metabolism of metastatin. Now let's get into the data with MBT. And MBT, in this study, it was roughly 40 patients, and they distinguished patients with controls versus early disease stage 1 to 2 fibrosis and then advanced fibrosis. And what it shows is that patients who have NASH, whether they have early fibrosis or late fibrosis, they have higher recovery of MBT and metabolism. And you can also see the peak on the right side is higher in patients with NASH when compared to control. This suggests increased potential microsomal activity in patients with NASH. This is a study that came out after that, and it showed something different. It tried to distinguish presence of NASH compared to patients who had simple steatosis and healthy controls. And as you can see in this instance, the peak is, first of all, blunted compared to controls as well as patients with fatty liver, and it's also moved further out, suggesting decreased microsomal activity. And then additionally, the amount of metastatin that was recovered, or cumulative recovery of metastatin, was also significantly lower in patients with NASH when compared to patients who had fatty liver or healthy controls. It had a good area under the curve, and it had good distinguishability between the two. But how do you reconcile these findings? One that shows patients have increased microsomal activity or increased metabolism, and the other that shows different. So remember, I mentioned that these breath tests, the prodrugs are dependent on extraction ratio. And the extraction ratio, if it's high, which it is for MBT, is affected by shunting. So in the first study, it excluded all patients with cirrhosis. However, the second study included patients with cirrhosis, and that's what you're seeing here is a shift in the peak as well as the size of the peak, the height of the peak in patients. And once again, if you look at it superficially, the data in MBT's ability to distinguish various stages of fibrosis, the data is phenomenal. But once again, if you parse through the data, you'd realize that part of the reason why this data may look so promising is because in the higher fibrosis cohort, you include patients with cirrhosis, which increases the accuracy of this test. And it's similar to the data that was presented with regards to transient elastography yesterday, where if the significant number of patients have cirrhosis, the predictability of transient elastography improves in predicting moderate fibrosis. This is a study that compared the accuracy of MBT in predicting presence of advanced fibrosis in chronic liver disease, mostly hepatitis C patients. And it compared it to routinely used clinical models of fibrosis, AST to platelet ratio index, or APRI, as well as the AST to ALT ratio. And as you can see, MBT outperformed both APRI as well as AST to ALT ratio in predicting presence of advanced fibrosis or cirrhosis. An important question that comes up is, can we identify patients who have clinically significant portal hypertension non-invasively and thus prevent them from having a liver biopsy and portal pressure measurements? And this study looked at NASH cirrhosis patients who were part of another clinical trial who had MBT performed, and it compares the accuracy of platelets, APRI, transient elastography, as well as MBT. And MBT outperformed other modalities in predicting presence of clinically significant portal hypertension. Now, if additional cutoffs are applied to the same data, the accuracy of MBT improves even more. So this has a potential use in clinical trials where we are looking at patients. So instead of biopsying every patient suspected of cirrhosis, we can start to stratify patients who may have abnormal MBT. Thus, we're optimizing the likelihood of recruiting patients who have clinically significant portal hypertension. What about the role of MBT in clinical outcomes? And this is a study that looked at MBT in patients who were being evaluated with cirrhosis evaluated for transplant. And it looked at liver-related death, and a number of co-authors are actually in the audience at this point. And so as you can see, MBT was a better predictor of liver-related death than MEL score. MEL score of 15 did not predict liver-related death. MEL score of 19, greater than 19 did, but it wasn't as good as MBT. This slide shows the prognostic value of MBT in predicting liver-related death in patients who have a MELD of less than 19. So this is sort of the MELD purgatory, where patients are sick, they may develop complications of liver transplant. However, the likelihood that they're going to get a transplant at that MELD is low. And in that cohort, MELD doesn't predict mortality as well or complications as well. And this shows that MBT in this cohort predicted the liver-related death. It predicted likelihood of decompensating events. It also predicted the development of ascites and exacerbation of ascites in these patients. Once again, underscoring its potential utility in patients with cirrhosis. This is a poster that was recently presented at EASL, and it looks at patients who've had a biopsy and an MBT, and this included a diverse cohort of patients with varying degrees of hepatic fibrosis. And it shows that if you had a low % drug recovery, it predicted the need for liver transplantation or liver-related death, and the lower it is, the more accurate and the higher accuracy the MBT has. When you compare that to liver biopsy, the line is essentially flat. So what's the state of breadth test in NAFLD in 2017? Well, the sad truth is that the studies are limited. There's few studies. They have small sample size. The population is histologically diverse and clinically diverse. Some studies do not distinguish between fatty liver, NASH, or varying degrees of fibrosis. The methodology is not standardized in the published literature thus far. For instance, the studies that I presented use varying degrees of metastatin. One study used 100 milligrams, and the other one used 60 milligrams. So there's varying degrees of, it's non-standardized. However, as this technology is being adopted by companies, the methodology is becoming more and more standardized with breadth ID and excellence. We also don't understand what's the optimal endpoint in these patients. Is it the height of the peak? Is it the time to peak? Is it the cumulative drug recovery, or is it composite? We don't really know because the published literature is very limited at this point. And finally, we don't understand what the accuracy is. How well can this test distinguish between no disease and disease state, between varying degrees of fibrosis, between NASH versus fatty liver disease? And then finally, how reproducible is this data? Because the studies are limited, the data that has been presented have shown varying results. So we need more data with this technology. And finally, the ability to detect change. And this is an important thing which I think has a major role both in clinical practice as well as research practice. As I have shown you that this is able to predict who has clinically significant portal hypertension and who doesn't. And if we're able to use MBT, we can actually identify patients who are improving over time without having to subject them to invasive procedures in clinical trials. So the bottom line is, it's not ready for prime time for diagnosis of fatty liver, diagnosis of NASH, or varying degrees of fibrosis, and we need more data. However, there are some clinical applications of this test that are very, that I think the test is ready for. And one of them is, as I've shown you, a robust study that showed that MBT was able to identify patients who were at risk for complications with cirrhosis, and it predicted better than MEL score who was going to develop these complications, who was going to decompensate, and who was at increased risk for mortality. I did not show you the data with regards to acute liver failure, but the data is also promising. In patients presenting with acute liver failure, MBT was able to predict recovery in a number of these patients prior to some of the routinely used prognostic indicators. And there's ongoing studies with excellence in acute liver failure. And then finally, from a research perspective, it's important to enrich our patient population. And I think MBT it has a significant role within that realm. Rather than subjecting every single patient suspected who has a transient elastography over X, and we can debate what X is, we can do MBT in these patients, and then patients who have abnormal MBT values suggestive of clinically significant portal hypertension then can undergo portal pressure measurements and liver biopsy to confirm those findings. This will reduce cost associated with studies. It will reduce risk to the patient. And then finally, a number of these patients don't follow the usual prognostic indicators, so MELD may not predict what's the likelihood that they're going to decompensate. So in patients who are part of these anti-fibrosis trials who have signs of portal hypertension, or have clinically significant portal hypertension, they may not be able to complete a year-long study. However, if you use MBT in this patient population, you may be able to predict with some accuracy who's going to decompensate, who has at risk for decompensating and who is not, and therefore include patients who are not at risk for decompensating and not include patients who are at risk for decompensating. So more patients can actually finish the study so that the data that's acquired is interpretable. And that's it. Thank you.